Good morning, or actually good afternoon, pardon me. As you'll note, I guess you can see my screen. I hope that's the case. I've got it set up as share. No PowerPoint today. I want to have a dialogue, please. I want to answer one of the questions I put in the teaser for today, and that is why wear a mask? And I want to emphasize the sequence that I have here. Notice I say manners, civility, courtesy, others, fear, and safety. The reason why I emphasize the courtesy part of it is for good and bad reasons. There's dialogue on both sides about which matters, and quite honestly, those decisions about whether it works or doesn't work are not as important as when you're on the street and see a person approaching. They probably and often have fear, and I think that good old manners, if manners rules this case, it's pretty much going to take care of the issues. So my opinion, why wear a mask? Manner, civility, courtesy, others, fear, and safety. Now, if you review all of the literature on asymptomatic spread, I've seen studies as low as 5%. I've seen studies as high as 75%. And what accounts for such a wide range of asymptomatic spread is how they define one, asymptomatic, and two, how soon after testing might they develop symptoms. So you can't be very well guided by what is or is not asymptomatic spread. It's out there, it's not zero in any study. So you should keep in mind that waiting for the statistics to come in on risk of asymptomatic spread is kind of, I guess it's a little strong to say a fool's errand, but the fact is there is asymptomatic spread. And in that setting, you're being courteous, showing manner, civility, and you're at least having some impact on your risk and others' risk if you are one of those asymptomatic carriers. I'll get into this in more detail when we talk a little bit about methods of spread. Effectiveness, and again, I'll talk about this in more detail. Do not forget fomites. Now, you notice another thing I put in the tease is not to think of this in terms of spikes and waves. If you look at it across enough populations, enough times, and smooth it, which you kind of are forced to do if you're going to make anything of it, it's just a straight line. Well, at an angle, there's a certain slope to the angle, but it's just going up. That's just, it goes up. And so the apparent waves and spikes are in some sense an artifact of different populations coming into the statistics at different times from different countries and so on and so forth. It's just simply accreting. The example I give you is like silt after a sandstorm, not just up and down, it's just building up. It is going to build up. This is a respiratory infection. It's in the air. And yes, you are getting exposed to it, even if you've got an N95 or another form and you're out in the world. Now, that's both good and bad. The good of that is it's still the possibility of having some incremental immunity by that exposure. This is how it happens across populations with similar situations. People have an infectious inoculum small enough that they don't actually get the illness, but they begin to accrete or build up some immunity. By the way, the sandstorm image is not just from being in Iraq, but my own childhood in West Texas. The silt gets in no matter how good you're sealed against the sandstorm itself. So again, don't forget fomites. That's part of this accretion. That's part of this inexorable buildup. It's in the air. We all breathe, whether you've got even if you have a mask on, the air still goes out and you take some air in. So I'm trying to offer that not to frighten you, but to have some sense the boundaries of your fear so that you're not worried about, oh, I've got my mask. I don't have my mask. I've been in the wrong place. I did the right place. Just be careful. And don't forget fomites. Everybody tends to want to focus on the mass spreads, like the fellow at Phizer who came in as an inflatable Christmas tree and apparently got 60 people sick. But those matter, but that's not the statistical risk that most of us face. So anyway, that's just some issues I wanted to clear up with you. Wear a mask, doggone ya. I think all of you guys will, but I'm just making sure that you understand the importance of that. Now, I have a process I want to go through with you guys. And by the way, I'm going to give you a page with all these links. This is what this kind of in the period of kind of dynamic information. I thought giving you these links will be more effective in terms of, if you choose to be able to follow what's going on with vaccines and disease risk and so on and so forth. One of the better ones is Covid19.ca.gov. This is the question I've been asked many times: when do I get my vaccine? And it's on here. And by the way, I need to cover this. If you find a way around these protocols, the person who helped you around those protocols will lose their license. This has gotten to be a big legal issue. So be careful, okay? Now, according to Covid19.ca.gov, this is how the vaccine plan for California is to proceed. Phase 1A, those are patient-facing personnel. That's everywhere from the lady who takes your, information when you walk in the door, to the physicians, to the PAs, to the nurses, and everybody else, including the administrative staff. They're patient-facing. That, at least in California, is estimated to be about 3 million people. To put that in context, here's how many shots or how many vaccines have been administered in California, and it's about, as you can see, rounded off 500,000, a long way from the 3 million of just phase 1A. It's not rolling out as fast as everyone had hoped, and I think you should keep that in mind in terms of your assessment of risk. This isn't going to come out as fast as we'd hoped it would. It's just that's reality. Now, phase 1B. Yes, as you can see, this link I will send you so you can check and see where you fit on this. A lot of these will eventually be administered, as immunizations have tended to be lately, through the pharmacies, Walgreens, and I think I've seen even Safeway on the list. But in other words, just most places don't have pharmacies. It should be available. This has to do with, of course, the type of vaccine, and that's another thing to keep in mind. So this is to put it in perspective, 3 million before it even gets to the general population. I mean, you can have mine, but it doesn't work that way. The other issue is, while those are our goals, the amount of people that are agreeing to the immunization is less than everyone had hoped for. And just to put it in the theoretical realm, it is less than what would help what would constitute herd immunity. So starting back 6 months or so ago, the agreed or desire to have the vaccine was in the 70 to 80% range, and across the population it's fallen now to as low as 40%. Among healthcare personnel, it's 60 to 70%. So there are people who aren't going to get this thing, and there's some arguments for and against it, but that will affect the public health in some ways that matter. To show you what kinds have been given in Santa Clara County, as you can see, Phizer 40,000, Moderna 66, 70,000. We seem to be getting more of the Moderna. The Moderna is a little easier in terms of storage and transportation, and that's why we're seeing that. But these are the two to get. I want to talk a little bit about that. There are a couple of mechanisms. There's a third mechanism, but there's primarily two mechanisms of the current generations of vaccines. One is a straightforward mRNA. I looked for mostly when I looked for graphs, I found complex ones of looking at genetics and transcription and translation. This one's simple enough. I thought it was kind of cool. DNA, mRNA reads that, and mRNA reads that and turns that into proteins. That's, after all, what our DNA codes for, is proteins. The mRNA in this particular case is for the spike. Oh, somebody needs to go on mute. I guess I'll mute you. Yeah, it's not working. Any event, the mRNA is what's called an epitope, a small piece of the genetic information of the virus, which is an RNA virus, by the way. In any event, the small piece then is injected and creates an immune response. The body says, oh, I don't like this because it's now this mRNA is making the spike protein. Now notice our body's responding to the spike protein, not the mRNA, although there is a reaction to that as well. And so the body now recognizes the spike protein. The spike protein is how the virus attaches to the lining of the lungs and throat and so on and so forth. And that's how it's introduced into the system. And so if you can block this spike binding, you basically block the virus. So it's that simple. It's an mRNA. The other one that's out there, AstraZeneca, and actually about 3 others, what they've done is taken what's called a rhinovirus, which is a common cold kind of a virus, and they've stuck a little genetic epitope, another similar piece of genetic information that the virus is benign. Actually, they got it from monkeys, as I recall. And it's benign in humans. Be careful when doctors tell you that. And I'm playing. That then is transcribed, creates this environment where the immune system responds to it. Keep in mind, we have 2 basic kinds of immune system. They both are involved in our response to this. One is our adaptive immunity. That's where we learn about antibodies. And the other is a more ancient and primitive immune system. And that's mostly what are called cytotoxic T lymphocytes. That just the T cells is the good generic way to think of that. The T cells are less biologically specific. They just know somebody's a bad guy and it goes over there and tries to kill the cell that's infected. It doesn't so much address the infection. And then when that happens, of course, it can't spread within the system. So this primitive immune system, the T cell response, is very durable, is apparently more durable than the adaptive immune response. What we believe at this point, there's evidence that the immunizations, all of them, induce both kinds, this primitive immune system, T cell mediated, and this adaptive immune system, the antibody version. So if somebody offers you AstraZeneca or Moderna, in my opinion, go for the Moderna or the Pfizer. Those are the way to go. Less of the intermediary issues of another virus and another immune challenge, and the specificity of how that is interpreted and expressed as a protein. So I love the Pfizer and the Moderna of what we have. I got some more information I thought you might find useful. I look around for where can you get information that answers your questions, because we can go through an awful lot of time just answering some basic questions. This turns out is from Children's Hospital of Philadelphia, and it actually gives a pretty good overview of what the mRNA is, what's in there, 4 different kinds of fats. Some of these are pretty straightforward. A little cholesterol, that's got to be good for you, and some salts and sugar. What it does do is clear up what I think is a fear that I've heard from a number of people. Gee, if I get that shot, will I be contagious because of the shot? And there are some versions of shots or vaccines that do make you transiently spread, but that is not the case with the mRNA. So once you have gotten an immune response, you're not going to get any spread from the shot, and 2, you then begin to have immunity pretty quickly, because mRNA doesn't last very long in the body. What this leaves out, or what this actually incorrectly states, and I kind of try to point you to things that are always true, and there's not quite any such thing. There is a discussion in here, where the heck, I probably went right by it, about reverse transcriptase. And it is the case, it states that there are no reverse transcriptases in humans. That is not true. There are transponens. There's a lot of different things that function as a reverse transcriptase. The reason why I'm addressing that directly is one of the fear things out there is, oh, gee, if I take that mRNA, that's going to be incorporated in my DNA, and now I've got making this weird expression of this spike protein. Yes, there are, in fact, versions of reverse transcriptase that are normal to humans, but as a basic fact, that's not going to be a functional issue. HIV, hepatitis B, some others incorporate a reverse transcriptase function to get propagated within the system. So I'm just telling you, that's there. Don't let them quite mislead you, but it's not a risk for lots of reasons we are actually more complicated than we need to go into. So then the question becomes, how am I going to find out if I've got it or not? As you know, we've sent this to you before. I'll send it to you again. There's a link for doing it with the county, and there's a couple of private ones. For those of you, and I think this might be something you'll think about, there are some home kits. One is by LabCorp. You just basically order it. You don't need any docs involved. You just order the kit. It's pretty inexpensive, and it's pretty straightforward how you do it. I mean, you know, just kind of the standard thing. So you can have some of those around if you have any concerns. The other one is from Abbott. This is a pretty cool system. This is, by the way, any of these that are not reverse or RNA PCRs, they're going to be on the order of 95% sensitive if it sees it, and only accurate, and 90% sensitive. In other words, they're going to miss 10% of the cases. Well, that's worth keeping in mind. If there's any symptoms or any other reason for suspicion or concern, I wouldn't trust a 90% as a cutoff point. But that's about what you're going to get from any of these things that are either enzyme linked or other kinds of functions other than PCR. There will be a nanoscale PCR coming out pretty soon. They've been working on it a long time. But as of now, one version or another, the ones I've just showed you, and there's probably more, that's how you're going to have to do it. Have these kits at home, test yourself, boom, you've got your answer. Now, it's worth doing, because if you don't do that, you will have some, well, let me put it this way. You will have some peace of mind about whether you're sick and whether you're a risk to others. And that's sort of the equation we're always trying to solve with this, okay? Now, I've got to get something else up here. Why is that in the way? How come I can't get that out of the way? I'm trying to get the, how do I grab this? Bear with me. Now, there it is. So that's the story on self-testing. So let's put these numbers in practical context. What's your risk? How's this affecting others? Currently in Santa Clara County, which is a pretty good indicator, they're running about 8% positive. There are some other numbers like this on the California numbers too, back here, if you want to look at those. This is the statewide as opposed to county. I picked the county because for a lot of us, that's going to be our risk environment. It's pretty similar now, but with that many positive cases, you know, that's running darn close to 1%. It's more than 1%, but on the order of 1% of people who get the disease will die from the disease. Well, that's pretty scary. Let's see if we can unpack it. 8% in Santa Clara County that are positive, and here's where it gets interesting. In Santa Clara County, there's 76,000 positives. That's not number done, and 771 deaths. It's starting to look really close to 1%, a little higher. But here's where it becomes reassuring for most of us. If you look at cases by age group, 80+% of the cases are in those 59 or younger. If you look at deaths, 85% of deaths are those 60 or older. So it's pretty easy to kind of hone in on where the risk is. I'm sorry, I'm just admitting some more. So since 85% of people who are carrying this thing and thus presumably contagious They're only 10 to 15%. If you're in this range, this is statistical noise up to basically 40. There are roughly 2 million people in Santa Clara. So there really aren't many that are dying that are under 50. But here's where it also becomes more focused. This is in Santa Clara County in long-term care facilities. Notice 340 deaths. Well, that's not that far. 40% of all deaths are in long-term care facilities. Now, the problem with long-term care facilities, we always tend to think that that's grandma and it's for only old people, but there are young people in those environments who have other health issues, and they are quite vulnerable in this setting. As you can see, that's darn near 10%. So that's a big issue. So if you go back to the other numbers, they're folded into this, but 85% of the deaths are 60 or older.
Is not coming up properly. I don't know what is happening. I really don't know. Okay, then go.
How would I know what?
Okay, close the door and go.
You guys mute yourselves, please.
Yeah, Sunil, mute yourself.
Trying to mute it. There. Try it again. So it's 60 and older. So age has a lot to do with it. That, however, is not the whole story. But so let's get on to some other aspects of it. If you look at this, these are the top 50 countries with the largest percentage of older adults. Japan is by far the oldest. They currently have just about the lowest incidence of COVID. But if you start to look around, you start to see some patterns. It is the older population, Italy, Greece, France. Yeah, it's starting to be those guys that have more of a problem. That's just true. So what you think about, back to my other numbers, 85% of 60 or older are the ones who die. And that's important. But even then, that's on the order of 2%. It's not higher than that. So these aging populations are the ones that are going to be at risk. United States is 16% over 65. Worldwide, I don't know if it's in here, it runs about 10% of the world population is 65 and older. So those are the people who are going to remain at risk until we've got a widespread immunity. Now, why is Japan low? Why is, Finland's not that high? We'll talk a little bit about that.
No.
I want you to keep this in mind. Notice this is 2017. This has nothing to do with COVID. When do you die? You die in December, January, February, March. That's in the northern hemisphere. It's, of course, the reverse of this in the southern hemisphere. So the seasons do affect this. It's not as if cold weather makes these bugs multiply more. It changes social behavior in a way that it impacts who dies when. We're now in the midst of the highest death rate. And that gets to the issue of what's the trade-off between COVID-related death or illness and other related death or illness that seems to be in this equation as well. So keep in mind, it's not surprising that it's higher now. It's not unique to the COVID. Now, I think it's important to do some work at, how would I put it? Differentiating. In other words, understanding that some of what you're seeing is not some unique, scary, horrible thing about the COVID. It's an aspect of the cycle of life and death within the human population across, across all of time and still in the modern world. So let's keep it that way. Now, I wanted to show you here. Okay, I hope you can see this. I put Brazil, United States, England, India, Mexico, and Japan. And who else did I have on here? Somebody else on here. This is currently the world death rate per 100,000. Globally, it's about 90.32. The worst guys up here, strangely enough, is England at a substantially higher per 100,000 death rate. They were one of the older, but not by any means the oldest. If I look down here at the United Kingdom, it's very little different than England. That's probably not surprising. United States at 113. Okay. Mexico, but look down here. Here's India, and there's Japan. Now, I will make a distinction between India and Japan, but I will tell you, in India, this is going to go up. Why? Not as high as it did in England. Why? Because if you'll remember, where is it? There just aren't that many in terms of relative age. India is not a very old country. Does have a lot of secondary diseases like diabetes and coronary artery disease, but they're just not as old. So their death rate's going to be a little different too. Anyway, if you want, I'm going to send you all these links so you can fiddle around and pick your favorite country or your least favorite country and find out how they track with respect to the rest of the world. Mexico is coming up. It's not reflected here, but I think Mexico is probably going to take off a little bit more. Whether any of them are going to catch England, I don't know. England's so far out, it's pretty much an outlier. So keep that in mind. Age of the population has effect, and social behavior has an effect. Social behavior, everything from who spits on the sidewalk to who washes their hands and who washes their face and who doesn't pick their proboscis. I'm not sure it's helpful to look at this one. I've always put it up there. I've shown it to you before. And the useful way to look at this is, as soon as it refreshes, pardon me. Oh, I got somebody waiting. Sorry. I think they're all admitted now. Where you want to see this, or where it's useful to see this, is the daily deaths. And this is, by the way, this little tiny thing down here, and it went up and it went down, that's China. And I don't know if you believe that or not, but that's just tiny, it's nothing. This is the rest of the world. We're all sort of, as it were, we're catching up early on. Well, we've certainly surpassed what they report. And as you can see in terms of daily deaths, there's clearly starting to be a crescendo. Now, this is an example where I'm going to try to talk you out of thinking in terms of waves and spikes. If you smooth this out, and even with this is a line. It's going straight up, and it's going to continue to go straight up, or not straight up, but up at a continuous rate. What that slope is, we can fiddle around with what our variables are, but it's going to keep going up. That is not the same thing as your personal risk is going to get worse. And I want you to think about that a little bit. We'll talk about how to think about that in a minute. All right, how do I get your pictures out of here, guys? It's not your fault. I put them in the wrong place. There. Now, here's why I want you to think about your behavior. I'm going to show you just a plain old number. I could have written it out, but I want you to see it. The diameter of one of these COVID particles is 125 nanometers, 0.125 microns. Probably most of you are familiar with what's called Brownian motion. And that's right at the same size. Now, Brownian motion, if you don't remember it, when you look, I guess the best example most people are familiar with is when you look, as it were, at the dust in a light, and you can see things just kind of floating around and particles coming around. That's an example of Brownian motion. It's a small particle, so small it's influenced by the randomness of gas molecules and other molecules in the air. That Brownian motion means that these viruses can float in the air indefinitely. Now, how people unpack that and make it sound less scary is, oh, it's aerosolized, or it's in some sort of bound state where it's not that big and it will fall to the ground eventually. But what I want you to understand, and this is one of the reasons with a respiratory disease it's going to keep going up, is this is everywhere. And that's good. We might develop this incremental immunity. I don't count on it. But the fact is, we're just becoming more and more surrounded by this virus. And it's not merely some bad guy going around with an asymptomatic expression of the virus. It's the nature of respiratory viruses. That's reassuring. This isn't bizarre or weird or different. And it's also concerning because it means we have that to face in the not too distant future. Well, I'm hoping I'll get some questions about that. I'm gonna leave that alone. This is it's being spread everywhere basically. And just for fun, I guess it's fun, I went to the CDC site to show you the similarities and difference between flu and COVID-19. Now, what's fun if they had a site like this and they don't, similarities and differences between flu, COVID-19, and the common cold. Turns out the symptom list is almost identical. And that's one of the reasons that it's a little confusing. In the modern world, and I hope you do this, assume you have COVID. Now, in terms of flu, normally this time of year, we'll have anywhere from 10 to 20% of tests for respiratory illness will be flu A. Now it's less than 1%, almost none of the tests are positive for flu A. Why? Because we have instituted some behavior that's changed our flu risk, but it hasn't affected this as much. And that's because it's a little more contagious, not wildly more. And that'll get, and I'm assuming I'll get some questions on this, that also includes the newer strains you keep reading about. And I'm sorry that they're trying to scare you with that, because from the very beginning, we've tracked like 15 different strains of this, because it, like all viruses, has a steady mutational rate and it's going to change. So this new one that came from England, that came from who knows what, and is now in Colorado, and you know the rest of the story. It's just going to be another one of these bugs. The harmful aspects of this particular virus, you know, the ACE binding sites and things like that are unaffected. So its lethality still hasn't changed much. In any case, it's not like SARS or MERS. Those were MERS killed everybody. That's why it didn't spread very much. And SARS, we were able to contain, or everyone was able to contain pretty early on. But those are another version of this same virus. So it's not as lethal as those terrible ones. It's significantly more lethal for older people than flu, but across the population, it's not that much different. Okay, so that's the background there.
Quick question, Dr. Mike.
Oh, sure.
So you said that the virus is everywhere. So, you know, we've had previously, what we heard was you had to be in a room within 6 feet of somebody without a mask on for 15 minutes, and then you could get infected.
No,
yes. Conventional wisdom now out the door?
Well, this is why I'm trying to get away from this idea of and I know my motivation may not be clear and I haven't explained it very well. The reason why I want you to get away from this idea of waves and spikes is it's going to be out there, and it's going to be out there more. And you are looking at a smear of statistical risk. And what you're trying to do is get on the right side of that normalized Gaussian distribution. How can I minimize your risk? And certainly the more likely you're in a room with someone contagious and you're closer and you either one or both don't have a mask on, you have a higher risk. But you don't have zero risk almost anywhere anymore. Does that answer your question?
Unmuting. Unfortunately, yes, it does answer.
Yeah, that's I can't change the way that story gets told. And I'm afraid it's not being made clear for people. So it's everywhere. Given the number of people who've agreed to take the shot or the vaccine, that will certainly have an impact on spread, but it will not terminate spread. And this particular class of viruses has been in the human population for tens of thousands of years. That's why we've all had a cold. And a common cold often involves another coronavirus, or several. There's a whole strain of human coronaviruses. So some of us will have some primitive, that this T cell mediated partial immunity, and that's a big part of why some people just don't get sick. They've seen it, their body's seen it or seen something near enough like it, and they don't get sick. But enough people, and unfortunately, this is kind of in the middle ages of life, we don't ever get colds anymore. And what happens is our immune repertoire, our immune memory just decays. And that's why when we get older, we get sick all the time. Forget COVID, we just get sicker as we're aging because our immune library has decreased. And so for all of us, or many of us who've been exposed to plain old colds and other similar kinds of viruses to this one, we may have some primitive initial immunity. We don't have to build up antibodies. We just kill the guys that have the cell and the virus gives up. Matter of fact, in some level, they never even shed the virus.
Hey, Mike,
Go ahead.
I've got a question about traveling on airplanes. I haven't been on an airplane since February
Right.
of last year. And you know from knowing me that I spent most of my life on planes.
Yes.
I think it's one of the filthiest places on earth, despite what the airlines tell you, and I have no intention of taking one anytime soon.
Right.
The other thing that I would cite, despite all this claim of air circulation on planes and things of that sort,
Yep.
is the TSA is the filthiest thing on earth.
Yes, also true.
You know, the trays and the stuff that goes through there, all that stuff. So maybe you want to give the group some advice on travel. I think nowhere unless it's on private.
Joe, you've given us a nice graphic image. Every one of us can remember those trays. I mean, I don't know about you. Shoes are in there. Who knows what's in there? I mean, and what are they going to do? Fog down the whole place? It's a filthy place. The air circulation in airplanes, they're all HEPA filters, and they've had HEPAs before, but they usually don't turn them on until lately, because they impact fuel efficiency. But even with HEPA, you've got so much local recirculation that you can certainly get this from a sick person on an airplane. So what constitutes need to travel is not mine to judge, but in terms of my advice, don't until you've had your vaccines and crossed yourself a few times. I mean, it's just a bad world out there. You're absolutely right, Joe.
Yeah, I'm not sure vaccinated I'm getting on a plane either.
Well, I'm just saying I wouldn't even think about it until that point in time. I'm pretty impressed or grateful, I guess, for these new immunizations. It's really remarkable what they've been able to achieve. What's nice and will matter for all of us, a lot of this mRNA research is going to impact many different kinds of diseases. And as they get better at this process, it's going to make a huge difference for other diseases. There's a long list of diseases where basically genetic diseases that you can intervene and repair through this without even going through CRISPR and some other forms of genetic change. So it's great technology, and it's wonderful that it's been effective in this case. I'll get my shot when I can. They right now haven't even finished with large institutions in Santa Clara Valley. The private practice guys, we're next. They told me yesterday that would let us know in the next day or two where to go line up and when to get our shots. Maybe there's questions about the risk or fear of that, and you're welcome to ask about those.
Actually, Dr. Mike, I'd like to know about the logistics of that, because I'm just here in Santa Clara and no place else in the world.
Right.
How are we going to know when we're eligible? Where do we find out? Where do we go? Are you going to do it from your office?
Well, so that's why I send you back to this one, and I'll send you the list of all these links. This Covid19.ca.gov one outlines specifically the sequence that we're required, and if anyone breaks this, you lose your license, kind of thing. And for the and by the way, get those Phizer and Moderna. It's going to be hard for even a small practice to do that, because it requires that you contract for these huge refrigeration systems and are administering the shots in that setting. But the point is, after this phased process has begun, after we've got phase 1A, and then we start to look at these people in this age, this is going to start happening pretty soon. And Phizer and Moderna, the primary distribution points are going to be pharmacies. And that's the current plan in California. You can sign up to be a distributor, but then they can't even get the silly things up here. We're in the process of moving my office to a ground level facility that'll actually have a gym, by the way. And then we may have a different story. But if, for example, if you go to Walgreens or CVS, at least as of a day or two ago, and these things are changing, you can actually just kind of be on the list and they'll call you when they're available in that setting. But we're quite a ways away from it, and it's going slower than anybody expected. Any other questions on that one?
Dr. Mike,
Yes.
it's Anita. I have a different question.
Okay.
We have someone in one of our stores who tested positive,
Yes.
asymptomatic. They
Yes.
only took the test because another employee they worked with, her son tested positive,
Right.
but not her.
Mm-hmm.
So in terms of everyone else that works there, like what's the ideal time to actually go get a COVID test? Like what are the protocols we should be following to not, since everybody's asymptomatic, not to infect each other,
Right.
not to spread it to customers, all that?
Right. Those are great questions. The thing that don't trust a single test. And in other words, when you go and get your test, are you in a phase where you haven't got enough viruses on board that you would even show positive, even though you eventually will? In other words, those viruses, once they get in the system, they multiply pretty rapidly. Or are you at a phase where you actually have had the disease and only initiated T-cell immunity, and it was enough to make you feel well, and then you're not contagious, even though you've had the disease? So there's a mix to that question. The only way to find out, gee, I've been around somebody even second or third hand who's positive, is to get one test and repeat the test about 5 to 7 days later. If you're positive, retest anywhere from 5 to 10 days later, and then a third time after that. So you don't just trust one number. That's one of the reasons I suggest you think about having some of these home kits. You can kind of, again, 90% likely are accurate, very sensitive, but I mean, and sensitivity is about 90%. So they can miss 10%. But if you've got these around and you have a question, you basically can answer it for yourself. And actually, these are relatively inexpensive. I mean, for example, the test we do here, the exact number I'm not familiar with, but it's $90 to the lab, and we pay $10 a kit. And it just involves $100 or so. And these are anywhere $25 or less, and they're pretty accurate. They're in that 90% range in terms of sensitivity and accuracy or precision. So I don't go by one number. I have a friend of a friend who had it, and I was around my friend. Consider that you need to be certain you don't have it. Now, the question then becomes, and you haven't asked that, but I'll assume you're somewhere in your thoughts, well, what do I do if I'm positive? Well, quite honestly, in most people's cases, again, back to those statistics, if you look at the 8% positive, and if you're in this age range, and quite honestly, if you're in this age range here and are otherwise healthy, you really have a pretty low percentage of risk of a fatal outcome or even a hospitalization. So one thing I advocate, and you've probably gotten this from me before, is your vitamin D levels. That's why I check vitamin D. Vitamin D protects against solid cancers. It protects against a range of infections, and also in long term, it's very helpful in terms of brain health. So keep your vitamin D levels up. And I usually go through that with everybody that tests here. Keep it in the mid to upper range, but take care of that.
That's another question with that vitamin D. So have been seeing people are going, some places are saying get 4,000 to 5,000 daily, as opposed to just 20,000 once a week.
Well, the issue, the way you choose between either one is how does your body respond? I have found for most of my patients, they actually get better blood levels over time taking it in pulse doses of 20,000 1 to 2 times a week. I've got others who take 5,000 a day and the numbers never go up. So that has to do with their gastrointestinal absorption threshold. That has to do with lots of other biological variables. On the other hand, I've got a lot of patients who take 5,000 a day. Their numbers are great. So to some extent, and this is what I always tell you, you know, that is be guided by the data. Is 20,000 once or twice a week keeping your numbers where it belongs? Then it's fine. 5,000 a day doesn't work, then you go to the pulse approach. So there's no one size fits all. Measure it. Make sure your levels are good. On this same topic, there are some crazy protocols out there of extremely high doses of vitamin D, and then the additional claim that there's no risk of toxicity. That's nonsense. We know from other studies that you can have neurotoxic, in other words, effects on your balance and brain effects, even though it's good for you. At too high a level, it can be toxic. So don't get, oh, I've got COVID, I'm going to take 100,000 units a day. Do not do that. But certainly make sure you've got your levels at a reasonable serum level. And the pulsing is not the issue, because it's a fat soluble vitamin, and it's not a vitamin, as you guys probably know. A definition of a vitamin is something the body's incapable of producing, and the body can produce it. It's just most of us don't run around naked all day in the sun, and therefore we don't have enough vitamin D. And that's about what it takes to generate it on our skin. So take plenty. What is that number? The number that works for you, and I measure that. The other thing that's meaningful is zinc. Now here's where you can get into problems. If you take very much zinc on a daily basis in an oral form, it actually can suppress your immune system. Taken enough on a regular basis, it boosts your immune system. And you should be having some zinc-rich foods, which is an easy list to look up. And it certainly includes oysters for those of us who like oysters. Okay. And the other thing about that is the effective zinc, and this has been looked at in everything from common colds to some other human coronaviruses, is the lozenge form. It works directly where this stuff is being taken up. It has both an ion effect and a blockage of cell. Well, bottom line is the mechanism is helpful for preventing the illness itself locally where it's being taken into the system. So, you know, I think, gee, I don't feel 100% and I was around somebody who's sick, start doing the zinc lozenges. It will make a difference. There are a number of protocols out there. I got one just the other day, and the list was your standard, this is good for my lungs, quercetin, which is in apple peeling, for example. And that's good for that. It's also good for allergies. So eat a red apple every now and then. That's maybe where that came from. But the point is, there are some other protocols out there, the ones that have clearly been shown to affect your risk of contracting the disease and your risk of going on to long COVID. That's the longest, you know, the prolonged form, is your vitamin D level makes a big impact on both of those variables.
Thanks.
Okay.
I have a question here from Avery.
Sure. Yeah, I agree.
Bringing it back to the Brownian particles and diameter. So
Right.
two related questions. So my question is, do N95 masks protect against particles that small for the virus? And a quick related question to that is, if fomites are still around all the time and kind of building up, what precautions do you take in your office to feel safe?
Well, what we do is, one, we change our shoes. We do not wear shoes into the office. And by we, I mean Phil and I, we will go around and we will wipe down the door handles, and we'll wipe down everything in the bathroom. And well, I confess, Phil mops the floor, and we scrub the Seika machine. We're at it on a and that's, by the way, well, let me finish that. We do that with each person who comes into the office. Okay. And so that level of cleanliness is important, but it's not going to be everything. Now back to the N95. The N95 actually works for many of the Brownian particles. Brownian particles anywhere from 100 nanometers to 300 or 400 nanometers. and the N95 will get a good range of those. But what actually does a better job, and is the HEPA. HEPA is really good for that Brownian level motion, and that's a good one. So make sure you've got a HEPA filter going. I've got one right behind me. I don't know if you can hear it. Those are a good thing too. So be good about, and it's gotten to the point where you can't even find them. But if you can, get yourself some HEPA filtration, even local, if it's not in your whole system. And I would, even if you had it in a house-wide HEPA system, have local HEPA systems as well. Local ones right where you're sitting and working and that sort of thing. Okay. Anyone else?
I have like 4 more questions unless.
Well, go ahead.
Okay, so the main question I had from what you had shown in one of the websites was for the virus after you've been vaccinated. I don't know
Avery,
if I
I lost
the...
you. I didn't hear you for a minute. I'm sorry.
Oh,
Re-say
no
that.
problem. So on the page about explaining the vaccines, I'm not sure if I heard the final verdict on if you can still spread the virus after you've been
No,
vaccinated.
you can't.
You can't? Okay.
Yes, and that's important because with some vaccines, you can still spread the thing for which you've received the vaccine. This is a different mechanism. It's not giving you the virus that you might partially shed. Okay, so that's not an issue. Now, there could be a slight window where, I was getting sick when I got the shot, and then you could have, some symptomatic spread. It should be shortened because of the the vaccine. But no, the vaccine, unlike some others we're familiar with, some of the old polio shots and some of the, another one is the shingle shot. You actually kind of have the virus in your system, and this is not like that. So you're not contagious.
But AstraZeneca's like
Get
that,
vaccinated. Why do you still have to wear a mask and social distance?
Well, I'll remind you that, in my opinion, you do it for manners, civility, courtesy, others' fear.
Right. So then.
Now, don't Avi, I know you won't. I know you've got a great heart, but I don't minimize that. I've had the experience, forgotten, and I was walking down the street and didn't have my mask on. I had it in my hand, for crying out loud, and I could see somebody, 10 yards down on the other side of the street look afraid. Well, that reminded me to put it on. No. I don't want to induce fear in anybody, so always wear them. So if you're asking this, go ahead.
I went on one of the websites, I forgot which one now, but they said that even if you got the the vaccine, you could still be a carrier. So is that inaccurate?
That's inaccurate. Now, wait, let me qualify that. It's accurate if, now notice I hope you guys can see my hands waving around here. There is a window where you may have been sick and got the vaccine, and then you would be multiplying and expressing the virus. Once you have the virus, you are not shedding the vaccine. You will not be shedding the virus. I wouldn't count on that until you've had both shots. In other words, with one is 21 days, the other is 28 days. So let me be clear. The shot itself, the vaccine itself, does not induce a shedding state. Okay. If you're shedding the virus after you've had the shot, it's because you had it already in your system at the time you got the vaccine, and your body hasn't completely processed the biology of clearing that from the vaccine. Your body will then start to shed it. So there's a window where you're shedding, but the net effect is you will not, assuming you've gotten the vaccines, both the first and second one, and you're one of those 95% of people that doesn't have it, and so on and so forth, you're not shedding it. But notice, even at the 95% level, which they make a big point of, that means 5% do not have immunity and can shed. So it never goes to zero. Now, that's the sense in which I assume that's the sense in which they're talking about. What I'm trying to separate, and I hope I have, is the shot itself, when it's effective, creates in a situation where you no longer shed the virus, nor can you shed the virus. You can't get it in the system. The body's very adept at killing it as it enters. But in that early phase, you could be shedding, not because of the vaccine, but because you already were sick at the time you received the vaccine. And don't count on the first shot as the full immunity. You need that second shot. at no point do you override the primary 4 reasons to wear a mask. Okay. I know I'm beating that to death, but I feel strongly about that.
No, very, very agreed. One question is you did say it will still spread after people get vaccinated. Is that because of the portion of people that don't get vaccinated anymore?
So there's 2 elements there. There's one, something between 20 and 40% who refuse to have it. They're going to continue to shed. And those people who are asymptomatic, and even if they've got a mask on, they're shedding. These particles are small enough that you literally can lay your hand on it and absorb it through your skin. Now, that's not a big source of transmission, but it is a short source. It's not that you touched it where it was and then you touch your face. At a theoretical level, just looking at the movement of particles on this size, it could actually be absorbed through skin. So it's always going to be out there. Does that kind of answer that? So separate those issues.
Thank you.
Well, go ahead.
Actually, Dr. Mike, I just wanted to clarify something. You're talking only about the 2 vaccines that are mRNA. Like
Yes.
the AstraZeneca can be different because it does have the dead
Yeah.
virus in it.
Yeah. Well,
And we
again,
don't
it's
have
not.
that yet, but we will.
Well, we will. And let me address that. There's been some discussion because of difficulty with distribution, acquisition, so on and so forth, that, gee, I got the Pfizer and now I'm going to get the AstraZeneca. Don't do that. And they're actually talking about this because of practical levels. We're having trouble distributing this stuff. It's just, it's a logistical issue. It's just the scale of the logistics is just, it's almost, well, it is mind boggling. Okay. But if you are in a setting where you've had Pfizer, I don't care if you get Moderna. I prefer you to get Pfizer, and Moderna. But I certainly don't want you getting, my first shot was a Pfizer, and my second shot, AstraZeneca.
Mm-hmm.
We don't have reliable data on that.
Mm-hmm. Dr. Mike, it's Marilee speaking. Could I ask a question about phase 1B, a practical question?
Certainly.
You mentioned to go to the pharmacies and get on their list.
Right.
So we should be doing that now, going to our favorite pharmacy?
Sure.
Okay, they have lists already.
Well,
okay.
I know of at least some around here that do. I don't know that that's a universal policy. I have to confess that. But they've done that with, as many of you probably know, they did that same thing with the shingles shot. They just put you on a waiting list. And that's kind of the plan for here.
Okay, so that's good news. Thank you.
And they will be they will be forced to follow these protocols. And if they screw that up, they can lose their license. They've made it very clear to physicians, don't go give this to your buddy. I mean, that's, it seems obvious, but it's illegal. It's frankly illegal. Okay.
Okay, let's keep it legal.
Yeah.
Thank you.
Dr. Mike, this is Keith. I was wondering, how you doing? I was wondering, somebody asked in the chat as well, like, how long do you think these vaccines are going to be effective for? Like, is this once a year thing we have to have, or what do you think?
Okay, so 2 elements. One, we still don't completely know the relationship between the adaptive immune system and the more primitive immune system. We know that you're going to initially, the immune response is going to be primarily the adaptive immune system. We track it through antibodies, and the induction of the T cell effects probably takes a little longer, and it actually might be more durable. But as I mentioned earlier, there have already been dozens of these strains. Viruses mutate. And how much cross coverage there is, or how little cross coverage there is, we don't really know yet. What we know is you should at least get partial immunity from having had the shot, and that will help with a strain variant that you might be exposed to. But if I were going to guess, and it's a good guess, we're going to wind up as a pretty routine thing getting these shots. Does that answer your question?
Yeah, that's pretty good. Are you like maybe an annual thing, or you think it might? Yeah, okay, got it.
Yep.
Okay, thank you.
You bet. Anyone else?
Dr. Mike, this is John.
Hi, John.
Hi. The B117 variant. If its reproductive rate is 0.5 higher, doesn't that, even though it's not any more dangerous on a per case basis, what about the effect to the healthcare system of, isn't there an exponential risk of case increases?
Well,
number of cases.
Point you know, and again, that the first guesstimate says you're right. We're on the 20 to 50%. The R naught was a little higher. You know, the number of people that get it from you is in the 20 to 50% higher with that variant. We don't really have, I believe it may be more. Don't misunderstand my point. You've got to, I know you know this, it's taken us a year to get this far in understanding, assuming we were just looking at one bug. And so we don't know a lot about this yet. It may turn out that, yeah, its R naught is higher, but it has a shorter period of time that you're shedding it. In other words, the asymptomatic time frame might be shorter. Those are just issues we don't have answers to. Now, if it has a higher R naught, but your only asymptomatic risk is 2 or 3 days, like many colds, for example, you don't carry that around in an asymptomatic spread for 2 weeks. You can do that with this. So there's some other variables in just how more contagious it is, the R naught being higher. And I don't think we know those questions or the answers to those questions at this point. But to get to your point, let's suppose everything else is the same and all of a sudden we have a 50% higher initial rate of spread. Yeah, that would be a serious issue. Keep in mind, I hope I kind of covered this. This is in Santa Clara County, because we can feel it kind of closely here, even though you guys are in the remote north up there. This talks about standard maximum ICU bed capacity. And what that number is pretty much the number of ICU beds where they've gotten nurse allocated and so on and so forth. And it includes the number of spare or backup or reserve that are still allocated in terms of nursing care. The actual maximum is a lot higher. I've seen numbers at least twice this high, as we could handle that. But I've seen numbers to that effect. But the point is, this is not an imminent risk at the current level. It's too high. We get into staffing issues and room use and turnover and canceling elective surgery and that sort of thing. But so yeah, we're running high, but go back here. This is December, you know, that's pretty bad. If you look at it over a longer period of time, and you can do that, you can see it's been pretty high for a long time. Is that taken off? Yeah, it's up. And this is the COVID positive and the person of interest positive. But it's still been pretty high before we really got into serious problems with this disease. So it runs pretty high just as a baseline. So are we in trouble right now? Probably not. Does that 50% R naught increase put them at risk? It increases the risk. As of right now, we don't have a lot of the auxiliary things in place, which is, additional hospitals. You remember when it first started, we were building, makeshift hospitals and hospital ships and so on and so forth. We haven't even really deployed most of that capacity. So if I get it, am I going to survive in the ICU? I think the answer is absolutely yes at this point. Again, keep in mind, this is not trivial, that we're dramatically better at treating this disease than we were not so very long ago. And it wasn't from some brilliant new discovery. It's from the oldest drug in our armamentarium, and that's the steroids. You blast somebody at the right time in the sequence with what are called glucocorticoids. That's like prednisone, betamethasone. There are a lot of difference. And boom, you've turned off this huge inflammatory response, and a lot of the deaths that we saw in the early phase of this would have been prevented. The other thing that's changed is we're not putting people on ventilators as much as, which turned out to be a terrible thing for many people. So again, our management of the disease has improved substantially too. I think we've got some capacity to handle some more growth, and I like growth rather than surge. I feel like that's kind of a hard sell, but I'm looking at it more like, here's a math equation. How do I track it? Anyway, so that's my answer to that question. Any other questions?
Yeah, Dr.
Sure.
It's Marilee again. A practical question about fomites, now that you are saying how much secretion there is in the air.
Right.
What do you do coming home from shopping or with foods that are like apples and non-packaged foods? And then what do you do with packaged foods? We had understood that you didn't have to wipe everything down. Now, are we going back to that practice?
Well, I have to answer that kind of in a personal level, I've never stopped that practice.
Okay, we
you
haven't
know,
either
yeah.
because we're super practical, but
Well,
yeah.
I'm just, you got to be, and I think you are, you have to be careful about any dogmatic statements about it is infectious, it's not infectious. I mean, it's just, they're wrong, okay? And there's nothing that's zero risk in this story. You do your best. We get all of our 99.9% of our groceries and things delivered to the front door, and it sits there. And how about your dairy products? Yeah, it's a little warmer than I'd like, but that's okay. And if there's one that we think has to be put away right away, we bring it in and we have wipes and sterilizers and all that sort of stuff, and we wipe it all down. Fruit is an example of that, and certainly your example of an apple. If it even stays out there, now depends on what time of the day they deliver it. One angle in our porch is nice and sunny, and I feel like it's kind of getting treated there and probably going to die there. I mean, the virus. So you're trying to you're trying to optimize that. You never will get it perfect, but I think I would continue that practice.
Okay, thank you.
Yeah, Dr. Mike, can I ask about hiking trails? What's your advice? I mean,
oh boy, isn't that a great question?
Huh? Saying it's a great question.
It's just a killer. Well, all right. I'm back to confession time. Bless me, Father, for I have sinned. I confess that I avoid heavy trails. Phil and I do hills a couple of times a week, and our favorite hill is now so overrun, we just don't even go there. And we found another place, and if that ever gets overrun, we'll go somewhere else. So I kind of make that a rule to stay away from busy trails. And when I have a non-busy trail, I don't wear a mask. I confess, I love fresh air, and that's just the way it is. But I'm very careful about not being on a crowded trail, because a crowded trail, yeah, it's fresh air, there's higher air turnover, and there's going to be less Brownian motion out there just because of winds and so on and so forth. But I would really make it an effort to not, wherever you happen to go, and well, you're not there anymore, but in Palo Alto, I've got 50 trails. I used to love to go around there. Well, most of them are overrun. I wouldn't do that. So I'd be careful about that, to be quite frank. And if you're going to be on a crowded trail, yeah, you've got your mask on.
What's the danger of rebreathing carbon dioxide if you're running with a mask on?
It depends on your lungs a lot. Gas diffusion, for example, some people are good about taking up oxygen and they're bad about carbon dioxide clearance. Most of us are much better at carbon dioxide clearance than we are at oxygen uptake. That's why our body is tuned to CO2 levels more than it is O2 levels. The drive to breathe comes from our body's CO2 levels. So only in lung disease is it come from O2 levels. So our body is very sensitive to CO2. And what you'll find if you try to do that with a mask is your breathing changes, and you might get into shorter, deeper, more frequent, or shorter, more frequent breathing just to drive the CO2 out of the system. The body's pH level, the blood's pH level, is very dependent on CO2 levels. Carbonic acid, which is a combination of CO2 and water, regulates the blood pH. And most of our cells depend on very precise blood pH management. And that's a CO2 dependent issue. So what did I just say? What I'm telling you is your body's going to pretty much drive you to compensate for that. And it's not zero, but it's very low risk that you're going to wind up CO2 toxic. And I would pay attention to the feedback system. I'm more out of breath at this hill than I usually am. Well, then slow down. But I don't think it's a big risk, as long as you're conscious that there's a change and the body's very dependent on its CO2 level. You'll find yourself getting dizzy in a way you wouldn't have otherwise. And that means your blood pH is shifted because of the built up in the CO2 levels. As you just heard, I can't give you an equation for it, but I am giving you some subjective sensory evidence of how to interpret it for yourself. I hope that helps. That's about the best I can give you on that one.
Well, can I understand that a little bit, Dr. Mike? Because I have a CO2 problem,
Yes,
and I
yes.
get dizzy when I'm hiking.
Yes, right. Yes, that's right.
Okay, wow,
Yeah, that's what that is.
no kidding.
You and I both have that one. We know that story, right?
Yeah, sadly.
Yeah.
Dr. Mike, this is more of a personal question, but
Okay.
you know how they've been talking about if you're anaphylactic, you may have to be careful with getting the vaccine and stuff like that. Could you speak to that a little bit?
I hope that hasn't quite been the message. One of the reasons I showed you this thing from the hospital is it just happened to be the best kind of online answer thing. The things that they're talking about that are in this first of all, you've got no anaphylaxis to mRNA. Your body's full of it. So it's not like the main thing is an issue. These are simple fats and simple salts and sugar. That's the only thing in this. This doesn't have some of these toxic preservatives and that people react to. It doesn't come from eggs. It doesn't come from other cell lines. This is stainless steel stuff. So I think that that's overstated, period. Okay. Just period.
Okay, thank you.
Anyone else?
Is there any more data on the long-term health effects now that some cases have, been around for over a year?
Yeah, there is. And there's a lot of forced science happens during war and during pandemics, and the forced science has just been amazing. In this case, we now know about some mutational changes in a person's genome that puts them at risk, for example, for long COVID of the brain or long COVID of the heart or long COVID of the lungs. And what we know is the mutational rate that's associated with that is very, very low. So, and by the way, these are mutational changes that we might not have ever seen if they didn't get this particular disease. So they would appear to be healthy and be healthy for most of their life in most settings. So where I'm going with that is, it seems like the majority of those cases, there was something odd or wrong to begin with. It wasn't, gee, it just happens randomly to some 20-year-old. So we've got a lot of really remarkable understanding about the genetics of risk for long COVID or directed long-term COVID. For what it's worth, and this is just, in my patient cohort, by far the worst symptom has been the stunning 100% loss of smell and taste. And these are people who are other people going around with flu and shortness of breath. They don't seem as upset as the people who've lost taste and smell. It's that central to how we interact with the world. And I'm not making fun of it. I mean, it's devastating to them. So that I've heard that probably more than anything else. But that there are cases of that lasting 6 months so far. Most people, it's a month or less. So did your question, it's a real issue, but it's so specific that it's not some random thing. We're beginning to start some true point genetic mutational risk, and most likely you won't have that.
Okay, thank you. Okay, that makes sense. And this sounds like a facetious question, but it's not. Like, when will this ever be fully over? And like, what, to try to have a more positive spin, like what is our way out of this? Yeah,
well, it's not, or I certainly wouldn't take it as facetious. The answer is it's always going to be with us. And it's going to become a scaled, incorporated risk. Some of the behavioral economists are starting to look at how many not just life years, but quality of life years are actually being lost. And as you know from this one table, most of the people that are going to get this are not going to live very long anyway. I hate to say it, I'm one of those people, but in terms of how many of you, do you need to be worrying about its effect on your life? Of course, there are those you love and care for who would be at risk and might potentially be those who die. But in terms of life risk for people who are older, You know, a lot of 90-year-olds are going to die pretty soon. A lot of 80, 90-year-old people are going to die pretty soon. And that's true of almost all of the people at risk. They probably have not a great life expectancy at the time they become ill. So I think in some sense, oh boy, we're going to get clear about who's at risk and adapt our behavior to accommodate those at risk, and the rest of you guys get to go about your business. That's where I think we're going to wind up. Coronavirus entered the human species tens of thousands of years ago, other forms of it, and I think we're not going to get rid of it.
Mike, could you address?
Oh, by the way, Avery, I actually think that's good news because we're not going to have to stay in this generic, widespread fear status. Or we don't have to, at least at a statistical risk.
That was the only question. Thank you so much.
Yeah. Mike, could you address children and the virus again? Thinking about, say, grandkids. We've got a bunch who are in teenage years, and one of them goes to a small private school, and he's actually going to school.
Sure.
And then exposure of wanting to see these kids. Should we totally stay away from that age level?
Boy, Mary Lee, I have a number. Well, me too. A number of my patients have grandchildren, and this has already been a heartbreak for them. I mean, you know, they're not seeing them, or their parents who their own children won't let them see their grandkids. It's a real, it's a deep and real tragedy. That's one of the reasons you want to I would make an effort to have more readily available testing, like these home kits. You know, you check that on a regular basis. I'm negative, I'm not worried, I'm going to go ahead, or check the kids or something like that. In other words, we're going to have to incorporate for those at risk. Who's those at risk? Here are these guys. For those at risk, we have to be careful, but we need to have some in place way to be careful other than just complete avoidance. Humans need touch. Humans need to see the face and the response and emotion and expressiveness of the face. That is deep biological wiring, and that has to be in the equation. We're going to wind up with some emotionally damaged people, not just because they've been isolated, but because they haven't been touched and they haven't seen the face of those they love and care for. So that has to change. And something like these kinds of testing, and there are others, but these are just a couple that are, you know, LabCorp's are good and Pfizer's pretty good. Those are ones you can kind of trust 90%. And when you get this kind of testing incorporated in your behavior, then you can start saying, oh, let's go see the grandkids.
Sure. Okay.
You know? Okay.
Yeah, that's good. Thank you.
Okay, sure. Anyone else?
I've got a question.
Yes, sir. Ma'am.
Louise here.
Yes.
Okay. So
that's my old Texas thing. Everybody's yes, sir, yes, ma'am. So forgive me. Go ahead. What's the question, Louise?
Do you think that some of the deaths in long-term care facilities are just because of the lack of contact?
Absolutely. I'm not going to qualify that.
We can do about that.
Well,
I think it's terrible that they're isolated.
Oh, it's horrible. That's why, and I keep pointing to it, but that's why I think this kind of at-home quick testing is how we're going to solve that. If you know that your grandkid coming to visit you in the nursing home, as they used to call it, is negative, that you just tested it right outside the door, and you're negative, you just tested it, and then you get the hug from your grandchild. I think that's just a matter of let's get in place some easy, rapid testing. I don't believe test and trace is going to be very helpful, but I do believe point testing is going to be a big factor in opening up those places for those people. It just has to happen, Louise. I agree with you 100%. I'm going to start crying when I think about how much social and emotional deprivation all of us are going through. It's not right.
The thing that's tricky with that testing too is, you know, having the 5 days of incubation, which I think a lot of people don't know. If they get a negative test, they'll think they're good, but that is really only indicative of the 5 days before you swabbed plus the 1 day it took to get your result or more.
Well, that's also, yeah, and that you'll know, and you heard me say that. You don't believe one test. That's exactly right. You got to make sure. Absolutely. That's why we need some, and we're getting there. There's, again, it's I mean, it's a great business opportunity. Develop one of these blasted tests that, you know, costs a nickel to make and you can sell a dime to make and you can sell for $1. I mean, this is just, everybody have 100 of them at home right now. And that's going to happen. And when that happens, we can change the timeline of unknown risk. And once we can change that timeline of unknown risk, we can get back, for those at risk, to a lot more social behavior.
One last question, maybe. As a percentage, without giving any privacy information away,
yeah.
What percentage of your current patients have tested positive for COVID?
Round number, 10%.
Interesting.
And why? Some of them still continue to travel. That's what I think the biggest issue has been.
Oh, thank you.
Do I sound like I'm down on travel? Yeah, I am.
I know, it's killing me. It's killing me.
I know.
No, it's not, 'cause you're staying home.
Are you down on air travel only or car travel as well?
Well, I mean, I'm my favorite own private plane, but car travel's fine. But then you're going to fill the gas, and you're going to. I mean, there's just some other exposures along the way. Do I think you can safely drive to Southern California? Who would, right now, in your car? Yeah, I do. I believe you can. But
well, I bring that up because that's at least one way to break up the, you know, let's call it monotony.
Oh, it is monotony. Sure it is.
Yeah, right.
But where are you going to
go? I mean, it's a pretty good. I mean, we're lucky. We're fortunate. You know, it's a good monotony compared to what other people are going through, but it still is very draining emotionally.
Dennis, if there were ever a time to say, my God, I'm a fortunate human being, all of us around here, it's just amazing. You know, I'm on 6 acres. I can walk around. We're all of us are just amazingly, I am grateful. I'm sure you are too. But you know, the problem with me is, you know, I've got a sister-in-law down in LA, but you know, I don't know how careful she is. I'm just giving examples. So I worry about even travel in that sense. But you know, going out for an old car ride, maybe that's some. I think that would be safe.
Right. So
depends on how fast you go.
Yeah, that's right.
Say if you know, were to outdoor gather and like actually be, you know, 10 feet away and camp separately, how safe are outdoor gatherings if they are done correctly?
And again, you got to keep in mind, and I've probably done it while you're watching me. Here I am doing it to show you. We so often unconsciously do things that, you know, if you were under remote control and we had some kind of electromagnetic field around you and you couldn't possibly get more than, you know, as close as 10 feet to somebody and they'd be perfectly safe. Well, what about the air and how much air movement is? Well, you're safer outside than inside, you know? So yes, it can be safe, but there's so much unconscious behavior that overrides those distancing. I still see people walk up to people and start to hug them. You know, well, wait a minute, you might not want to do that. You don't know that person. And I've done this myself in certain settings, reach out to shake somebody's hand. That's, you know, 1,000 years of training. So that's the only thing that I would be concerned about a group. How many are you actually carefully observing? Matter of fact, it might be like, you know, having a designated driver. You have a designated, you know, scold that's watching everybody else's behavior.
Oh yes, that is me with all of my friends. So
okay,
people can hire me to be the designated scold.
Good. Well, it's an important function.
I have a question. Can you address children going to school in person?
I think they should. I think that their emotional lives are going to be dramatically impacted ever after. Again, go back here, look at this. 19 or younger, 0.1%, and yet they're, you know, 18% of the positive cases. Their risk is just trivial. And when you look at their lifetime effects, And that has to be, you know, a lot of behavioral economists look at this kind of thing. You look in terms of how many are going to become drug addicts, you know, the standard list, drug addicts and ZOD, you know, you can go through that list. Even after you've taken away these big scary ones, the long-term effect, what's going to be the effect on autism spectrum? You know, a lot of people in the early, milder parts of autism spectrum, enough social interaction, and you wouldn't tell them from a normal person, but put them in isolation and they're going to be impacted in terms of behavioral, their job risk, their job potential, well, except for being an engineer. Okay, you guys can laugh at that. It's going to be worse for their life. So this is going to impact them forever. And I think we need to be more cognizant of that when we make these decisions. That's my opinion.
Yes, but remember the teachers.
Yep, that's let's remember the teachers. Most, I don't know, when I was a kid, the teachers were 30, some were 20 and some of them were 30. And there may have been an older, well, there were a couple of gray heads, some of my best teachers, by the way. And there are ways to protect them. You know, fine, they've got on a spacesuit, but that now the kids don't need to be around each other. My opinion.
I just want to clarify one last thing. So if we were going to meet with another couple outdoors,
right?
Are you saying that's not a good idea? It's okay. What?
What I'm saying, I'm a little bit like these hypocrites that make the rules and don't follow the rules. In other words, I can see why people just kind of give up and say, "Oh God, I've got to see my friends," and you know, is that their lifetime best risk decision? Maybe not. Is that enough of a risk?
Flex cards for each card.
That is there enough of a risk?
Set and set.
Okay.
No problem.
You're on speaker.
Yeah. There is some risk. That's just a fact. But I think the emotional needs, the social needs, maybe even the other elements have to be part of the equation on that one-on-one decision. But if you're asking me, is it zero risk? The answer is no.
You suggest then definitely not eating, or if you were 10 feet apart, or what?
I don't think the eating is the risk. What's that? Oh, okay. I don't think eating is the risk. I think just the proximity is the issue, and how much air circulation, recirculation there is in the environment. You know, if you're all, you know, standing athwart a high wind and you're across from each other, who cares? You know, you're not going to get it if you're 2 feet apart. If you're in a calm and there's high humidity, then it becomes more of an issue. So it's a calculated risk, and that's why I alluded. And I'm not excusing anybody, but that's why I alluded to the hypocrisy of those who make the rules and don't follow them. We're all had that kind of rubbed in our nose, but you understand it. When you finally get right down to it, sometimes you're driven to a personal decision, and that overrides some levels of prudence. Anything else?
Thank you.
No? Okay. Well, it's really been great to have you guys around. If you'd like, and I will anyway, probably, I'll go ahead and send out that link, that page as a list of links, just so you, and they're not the best in the world. Well, they're well chosen, but they're not the only ones. And you might find some that you like. It gives you information, but these are all vetted. And with the one of that Philadelphia hospital, which has that one kind of fudge about reverse transcriptase, the information is refreshed on a frequent basis and useful data. All right.
Great detail, Mike.
Thank you very much.
Thank you, Dr. Mike.
Thank you, Dr. Mike.
Bye, bye, you guys.
Thank you.
Bye, everybody. Stay
Bye-bye.
safe.
Yeah.
Thank you.
Thank you. Bye-bye.
Bye. Thank you.
You bet. Bye-bye.